I'm so glad you're here. This is a replay of a live training I did inside the OTs for Pelvic Health Facebook group with Lindsey Vestal, and I wanted to make sure that everyone gets access to it. Pelvic health is such an incredibly fulfilling specialty, and it's growing so much. I've been training OTs since 2018, and my goal is to have over 10,000 OTs trained by the year 2030. I'm so glad you're here learning about this specialty. I hope that you can join us in the OTs for Pelvic Health Facebook group with me, Lindsey Vestal. I will link to the group below in the show notes and description. Thank you so much.
We share gynecologists.
I love that.
Wait, we do.
We do?
We do.
You too?
Yeah.
Fantastic. Oh my gosh, what a joy. What a pleasure. Today's OT Empower Hour is so unique. It is so what I've been wanting to hear. We're going to be talking all about how teamwork makes the dream work, how OTs and PTs can work together in pelvic health. I'm joined by two incredible practitioners, Catherine Bergeron-Radu and Susan Yebra. Catherine is a PT, Susan is an OT, and both of them work together at Phoenix Physical Therapy in Burlington, Vermont. I am so excited to have you both here. Welcome to OT Empower Hour.
Thanks for having us.
Thank you. This is awesome. This is going to be such a great topic. So I start off every OT Empower Hour with an icebreaker question. It lets us know who's joining us. And I'm going to kick it over to you both before I introduce you. So let me know what your answer is. Susan, I'm going to start with you since you've been a returning guest. This is your second time on OT Empower Hour. What is your favorite seat on an airplane?
Oh, gosh. Oh, I haven't been on an airplane in a while. It depends. Do I have kids with me? I like the window. I like the window somewhere in the middle-ish, but not in the emergency exit.
Okay.
Yeah. Okay. That's a good one. So I prefer the aisle if I'm sitting by myself, but I prefer whichever seat my husband doesn't want, because I'm happy to get up early and often. And so if he wants to get up and makes me get up, I'm stoked about that. But I don't want to make him get up if he's looking at me and breathing and sleeping like this. So I want to have the flexibility, but I'm only 5'4", so I can like walk over seats and everything, and it's no problem.
Oh, that's fantastic. This question was on my mind because I just came back yesterday from Seattle filming the first OTs in pelvic health course for MedBridge. And so as I was preparing for our talk today, I was like, airplane seats and like the strategic place to be was on my mind. So I put
close
in my
enough,
answer.
But not too close to the bathroom.
Yeah. I think that's actually the key answer right there. It's not even where, it's just like not being close to the bathroom. Tiffany Lee is joining us. Welcome, Tiffany.
Hey,
she
Tiffany.
says that she loves both of you, and her answer is first class if she could afford it.
Well, yes. Next to the captain.
And she says aisle so she can get up and pee. Totally.
Yep. Mm-hmm.
All right. Keep the answers coming in. If you're on replay, we want to hear about it too. Your favorite seat on an airplane. All right. So this is a fantastic topic. I'm so pleased to have you both here. You have an extensive background. I'm going to post your bio to our comments because we have just so much fun stuff to talk about. And I literally feel like if I shared both of your bios right now, it'd probably take up a full half hour. Both of you are so accomplished and just fantastic practitioners. But we want to get into the collaboration aspect and this beautiful environment that both of you have created at Phoenix. So let's first just lean into a little bit about your skill set. So I'm not asking like what courses you've taken. I'm not asking any of that like resume stuff. Tell us a little bit more about like the skill sets that you really feel you bring to the table when you're working with clients, like what really lights you up. Catherine, we'll start with you.
Ooh, so I came from an ortho PT background, as most grads do. But I also personally came from an athletic background. Both my parents were very athletic and active, and my mom was a PE teacher, so that gives you a sign. But I've been in sports and just active my whole life, so that was kind of my perspective. But I also started teaching yoga several years ago and was a personal trainer before going to PT school. So, body movement was kind of my shtick. I have brought that into my pelvic PT practice as well. And it really helps me think bigger picture of what's a patient's kind of day-to-day like, right? Are they active skiers? Because we're in Vermont. Do they have little kids that they hold only on one hip, and which hip, right? Which I think we're all tuned into that kind of stuff, but maybe the kind of more sport specific or movement, certain movement specific kinesiology maybe is something I really like, and I think I'm very good at. But interestingly, prolapse has become a passion of mine, which is unrelated to all that, except maybe that it tends to factor a lot into athletes too,
Yeah.
And I just, I'm very passionate also about healthy body image, healthy habits, health at every size, right? And I think with prolapse comes a lot of body dysmorphia that I feel so empathetic about, because I think most people in our culture these days has struggled with some sort of body dysmorphia, body shame, and prolapse really impacts that. And I think anytime we can help women feel more supported and more empowered and more confident in their bodies, the better. And for me, that comes across in prolapse specifically. So I've come to love it, which I never thought I would. But here we are. And I tell my patients that every time when they come in really sad about their prolapse, I'm like, this is my favorite thing to treat. Let's go.
Oh, I love that. And I can imagine they feel so reassured when you say that, because that's exactly what you want to hear.
Yeah.
When you're working with someone, which I have prolapse, so I can 100% relate. That sounds amazing, Catherine. Thank you so much. Susan, what about you? What are your skill sets, and what do you love to treat?
Yeah. So with me being newer and having the last couple of months to have a little bit of everything, I like the pain population, I think, because this has been, in all my experiences in OT, this has been the experience where I can really get back into that mental health training that's part of our OT programs, right? And that's been very helpful. So, sometimes in the ortho settings, I felt very far removed from that. And in this setting, I feel like I've been able to come back to that full circle. What I love about this setting is there's just so much education to provide. And you really don't have to do everything all in one visit. It's going to be different. And when patients ask me, well, what's, they like to know, what's our plan? What are we doing next week and week after and week after? And I'm like, okay, well, I don't know because I have an idea, right? But I'm not going to say we're going to do X, Y, and Z next week. If you come in and you've had a terrible week and you had a death in the family, then we might just do more grounding or breathing or something just more low key. But if you're having a great week and you're feeling wonderful and you're ready to do something else, then we'll do that too. But really just having that, flexibility, and, with the pain population, there's so many varying levels of pain, and it's very, very subjective, very dependent on a lot of things. It could be fine one week, and then the next week, depending on what's going on in their life, it could be worse or better. And so just really following the patient's, lead in that. I've really enjoyed helping and seeing those patients kind of progress.
Yeah. And from what I remember, you have a little bit of background that is, you bring a little bit of energy work in. Can you tell us a little bit about that?
Yeah, so I actually, I'm part of the AOTA, the Integrative Health Community of Practice as well. And so Yeah, I am a Reiki master. I had done Reiki as a client for my own mental health and for anxiety and things like that. I loved it. And so I actually became certified. I was supposed to go do it actually at AOTA in 2020, but then it was canceled because of COVID. So I did it last year. I did a training and I integrate that with my clients. I teach them how to like scan their own bodies, how to focus on their chakras, kind of how to tune into those areas and see what feels, how they each feel different. If I'm working with, I had a fertility patient recently, and we're just doing a lot of that. She's kind of doing a lot of different things for her issues. And this was something new that I could offer her. And so that's what we've been doing. And she loves it. And it's been, yeah, it's been great. It's not for everybody, for sure. But for a lot of people, they are really open to it, and it's really helpful.
Excellent. All right. So Susan, from what I understand, you're a little bit of a new hire to Phoenix, right? Catherine, you've been there longer. So I want to know, when Susan was brought on team, right? She's the first occupational therapist, right? To join Phoenix?
Yes. Yeah. Mm-hmm.
So what was the staff reaction like?
Yeah. It was more of, it was great. I mean, it was, I guess, is COVID over? I don't know. It's still going on, right? Or something like it's like endemic now or whatever.
Yeah.
We're still in the times, right? We're not in the after yet. And obviously people are having staffing issues everywhere. So I think our first reaction was, yes, we finally found someone that'll be a good fit, right? That because that's particular, especially to a small private clinic. And so we had found a good fit. We heard really good things. In fact, one night we were out celebrating, we were having a dinner as a clinic, just the 4 or 5 of us or whatever. And I was texting back and forth with Susan saying like, oh, I can't wait to go here when you finally move to Vermont. And we still haven't been, but anyway.
You're asking what my blood type was.
Yeah. But I think we were really pleased to have found someone who fit within the clinic in a niche type of practice anyway, right? It's pelvic floor. And the fact that she was an OT was just incidental and different, but we didn't know why and we didn't know how. And I don't think that was a primary thought in any of our heads. It was like, great, another awesome woman to work with us. Like, let's go. Yeah, it was joy. It was joy.
Well, my next question was, what makes this environment work? And I think you just answered your own question. I think just that philosophy and that the fact that you were just like, fantastic, this is a good fit for us. We need someone in here to serve our public health clients. And her discipline didn't seem to matter.
No, I had more, I think I've had more questions like, Susan, please tell me what you know that I don't know, because I know I don't know things and I know you do know things. And I don't expect to ever treat the way she does and to have the same skill sets. But if I can even bring informed decision-making and know where my limits are to even give her a patient that I think might be more appropriate for sensory work or, whatever. It's just good to know that, but I didn't know what I didn't know. So I think those were my questions, right? Like, what don't I know about you that can help? And it's been really enriching.
Yeah. And I think that's kind of what you said in a nutshell is a sense of open-mindedness and collaboration that Catherine, you are very proud of the work that you do. That comes across really clear. And you also realize there's so much more to learn. And I think that mindset is what can really create an important environment. You guys could both be PTs, you could both be OTs, that doesn't matter. That mindset is incredibly unique and incredibly important for our own growth, for a good working environment. You guys have a staff of 4 or 5, being able to get along and have the day-to-day enjoyable is really important. It makes such a difference in our life. So I'd love to hear, Susan, maybe we'll start with you about some things you've learned from each other throughout the times you've been working together.
Oh boy.
Well, I had done your course, Lindsey and Laura's course, and I hadn't done any any of like the colorectal courses or anything like that. So I really was lacking in that area. So there was a particular patient that I had that had fallen on her tailbone. And I was like, I'm really not sure what to do. Like, I'm sure I can do something. I just don't know what to do. So I was like, Catherine, like, what can I do? And she's like, oh, well, then you can just do internal coccyx mobs. And I was like, oh. And so there I learned how to, start doing internal rectal work, which I, it's great when it's needed. It's very helpful and it is very helpful. Yeah. But that was definitely a learning experience. And Catherine actually came in and showed me with that patient, and the patient actually got better in like 2 visits and never came back. Great. She was like, I'm all better. I was like, great. So yeah, that's one example I think of a really insightful learning experience.
She was actually just on the ground the other day with my finger wrapped around externally her coccyx and pulling. And that was great. That was another learning opportunity.
Anytime Catherine's like, I ask her a question and she's like, all right, we'll get on the floor. Like, then I know something's coming, whether it's like positioning, like for a pain patient with sex or something, or trying to troubleshoot, like,
yeah, true.
The intake paperwork sometimes is very specific, and so we were troubleshooting positions. So anytime she's like, let's just get on the floor, just run through this.
I think we were discussing sex positions one time and enacting them.
The reverse cowgirl.
Oh, reverse cowgirl. Yeah, that came up.
Pain with there was a very specific list of positions that hurt and that didn't.
Yes.
So we were trying to figure out what was going on.
You're tuning in, don't flinch.
I noticed it was snowing in the background before we started, and I just moved to Flagstaff, Arizona. So it's my first time really living somewhere where it's snowing a lot. And I just want to know if you guys are hiring, because I want to come work there. It sounds amazing. I'm down with snow. I've got my snow boots. I think I'm ready.
It's always like this. We're not putting this on. This is our day to day
every day.
I love that. I love that. So if you guys don't mind, I'd love to just kind of put out there like a little case study, a little example client, and maybe we can go through, super quick overview of how you would start thinking about how to treat this client. And we'd love to hear it from both of your perspectives.
Okay.
So I'm thinking maybe a client who has endometriosis, right? And she's got pain with menstruation. And she's got pain with intimacy. I know that's not a whole lot of information, but love to just like hear your initial thoughts and even where your mind goes, just so that we can kind of see and learn from the two of you and your vast experience. Either one of you, whoever wants to go first on this one.
Okay, I'll go first. I would probably, first thing I would be interested in is getting a better idea of their stress and their stress level, and see if there's any correlation with pain and stress level. Obviously, I would ask what kind of diagnostic testing or ultrasound or anything like that they have maybe done, and where they are in their process. Is this something that they've been dealing with their whole life, or is this something new? I would, of course, ask as far as the intimacy is concerned, if penetration is important to them or if it's not, right? Because if it's not super important, then I may not focus on that. Ask them pretty much, when does it bother you? What is it impacting? Is it impacting work? Is it impacting your ability to work out? Is it impacting your ability to take care of your kids, whatever? And then I would probably talk more about their self-care and their mental health. Do you also have anxiety? Do you have depression, bipolar, anything like that going on? Are you seeing a mental health counselor? If not, how are you managing that? And what I have done, I guess, with some endometriosis patients that I haven't had too many that have been confirmed endo, but suspected. I had one that I never even did internal work with her. We never even, because she would just say, it's my whole body, history of PTSD, and it's my whole body. I just can't relax my body. And then I go to have intercourse and it's painful. And so once we talked about different techniques for just down regulation, for self-care, we went over positioning, same thing, don't squeeze your glutes when you're having sex. Just those types of things. We just worked completely on that on the outside. I did, and I would probably do, sometimes I'll have patients come in, and if they do have pain and it's really, really bad, I'll do lymphedema techniques. Like if you've ever had, it's a very superficial technique, but if you've ever had it done to you, it's very relaxing. So I'll do it on the head and neck. If there's constipation, I'll do the abdominal sequence. I may do some energy work. I may not, depending on their preferences. I may do just some body mapping, which is a lot of people in pediatrics are very familiar with that. It's just basically drawing the body, doing just some kind of like gentle compression, gentle squeezing. If their eyes are closed and they're comfortable, you can do it on the front and the back surfaces of the body. Perhaps like a yoga nidra script. So reading, bringing just awareness to other parts of the body, because sometimes we just get so focused on that painful part that we forget about the rest. Maybe internal if it's appropriate, or even just an external pelvic exam. I don't know. I think that's it.
Yeah, that's a lot. She didn't leave me much.
Sorry.
No, just kidding. Yeah. See, like body mapping. I had no idea. Gentle compression. I'm gonna have to ask her about that later. Sounds really really soothing. Just
my blanket.
I'll be on the ground later. Okay.
It's your turn to be on the ground, Kathleen.
Yeah. I have a nice heavy blanket that's just a regular blanket. It's not a weighted blanket. It's from like Kohl's, but it's just like a purple blanket. And one day you used it for a patient.
Purple blanket.
Yeah, it's because it's like it's not a heavy, but it's just a nice, comfortable kind of compression. So like sometimes I'll put that on my patient just for like a little extra proprioception.
I love that.
It was great. I went looking for that thing all over the clinic, and it was perfect, and my patient loved it.
For the endometriosis client, does anything else come to mind that you would kind of do?
Yeah, no, she covered a lot, and some things that I don't do that I think would be really helpful. I guess to add on, I guess I'll go when they first walk in, right? There's such a range of education about endometriosis, and how many practitioners they've seen of different disciplines, the degree to which they've gotten answers or not, the degree to which their testing has been helpful or not, and the degree of understanding they have. I've had everything from patients who say, my doctor told me something about and like they don't even know the word, but it was said to them, to patients who have had maybe multiple laparoscopies, and the pain went away for a while and it's come back, and they have a very good understanding of what it is, but they need more support. So I always start with kind of asking them, where are you coming from? What do you know? What questions do you still have about endometriosis that I may or may not be able to answer, but I'll try to find someone who can.
I love that.
And who are your other providers? Because we're very lucky here, actually in this same building, to have an excellent gynecologist who is my go-to for endometriosis, and she meets patients where they are and is just fabulous as a practitioner. So if they don't already have one who they work closely with, then I recommend either her, if they're comfortable with it, right? I always kind of propose it as an idea, or to find someone who can really support them through the more gynecological side of things, because they're going to need multiple different disciplines to fully support them holistically, because it is stress, it is diet, it is lifestyle, it is understanding what other comorbidities you have, because if you have Ehlers-Danlos, things are going to look really different, right? So I really like to get a good idea of where they're coming from, and also tell them, I can't take away your endometriosis. I may be able to help your symptoms. And for some people that's sufficient and it gives them quality of life and that's all they want. For other people, it's not enough, but we'll get you the people who can get you there.
Oh, I love that. Both of you are phenomenal. I love your thought process. I love how thoughtful you are. Just this ability to be a practitioner who thinks about the client and where they came from. What was their thought process before they walked in your door? Because these terms that our clients walk in with, these diagnoses they often have, are big words that are scary words that either they don't remember, or if they did, they use Dr. Google and it sent them into a tailspin. So I'm thinking also prolapse, Catherine, right?
Yeah.
And so I love that you're really stopping to consider the journey before they came in, and then what supportive role can you play along that journey, whether that's bringing in other additional referral parties, being a source of, you know, positive, accurate information, holding space for, do you have questions? I can't tell you the last time I went to a general practitioner who even had the time and space to ask me something like that, right? So such a gift, such a gift. I want to open up to see if anyone joining us has any questions for either one of you. This is such a unique opportunity to have you both on here. So you guys, if you're joining us live, if you have any questions for either one of our guests, please throw them in the comments. If you're on replay, same. We'd love to hear any thoughts that you have. While I'm waiting to see if any questions come in, I was wondering, you know, a lot of people wonder when there's an OTPT team. A couple questions that we get a lot are like whether or not you guys share clients. And if you do, what would be the scenario that you did? And then also, what about like the referral script, right? So a lot of times as OTs, we'll get a script for a PT. We kind of have to go back and get them to fix that. How do you guys handle that situation as well?
So in the beginning, of course, since I was the first OT, most of the referrals would either have the section that said like PT/OT/speech therapy, just kind of all circled, or some would say specifically PT, and we were having to do that and go back and get, you know, an OT specific referral. But now I think most of them coming through say, right, OT and PT,
Right.
because now they kind of like, I think a lot more
They've caught
they
on.
caught on. Yeah. And what else?
Yeah. So yeah, initially we had to edit our referrals and then send them out to clinics. But I think for the most part, unless they have a stack of our old referrals just sitting on their table, they're all sending us the new ones, which is good. And what was the other question about sharing?
Do you share clients?
Yeah. So generally, if you are a patient at this clinic, you get assigned a therapist according to perhaps, you know, a lot of our skill sets overlap, but some of us have specialties or just niche preferences, like, you know, male pain or whatever that maybe might go to one practitioner or another. But if a patient wants to change practitioners, that's fine, right? You should be comfortable, especially with the type of work that we do. So you could end up switching providers for that reason, but that wouldn't be sharing the patient. It would be a change of plan of care. In some cases though, and I think it's a growing thing that we're doing, which is great, we will utilize, embrace the fact that Susan has some skill sets that some of us don't, and vice versa, and co-treat with the patient's understanding of why we're, and their choice, right, of involving someone who has additional skill sets to support them. So lymphedema, right? Or in the case of me, and that was just a quick kind of me coming into the room with Susan, but doing the coccyx mobilization, right? So Susan got permission from the patient for me to come in and do it to the patient, but also teach Susan how to do it. So that wasn't quite co-treatment, but you know, those instances sometimes come up with patient consent. I think, you know, I more and more have been asking Susan a lot about kind of sensory work, right? Or sensory integration. Yeah, see, I don't even know. But that factors into bowel and bladder problems. And I don't treat pediatrics, but you know, it certainly goes up into the adult population. And I am more and more trying to pay attention to my patients and see if maybe that's something that they could benefit from.
And we've talked about, I've had a few patients that I've given the sensory profile to, and in terms of like sharing patients, I guess it was like kind of more of a consult. Jane actually had a patient that she was seeing, and she consulted with me for edema, possibly lymphedema, but it was like post-surgical edema. So I'm actually, so she's seeing that patient patient for the bowel and bladder, kind of traditional, I guess, pelvic health stuff. And then I'm doing more of the lymphedema, edema, compression garment type stuff. And then sometimes it's like a scheduling thing too. Like we all work different hours. So I had one that I had a patient that I had evaluated, and now she's on your schedule because it was a school thing, needed to come after school hours. And so she no longer seeing me, but is seeing Catherine. So we
but that's often just a shift in practitioners, not so much co-treating.
Yeah.
But I think the more, for me anyway, the longer I work with Susan and the better I understand what her skills are, probably the more I'm going to see opportunities for co-treating, because why not? If we have the resources here, it'd be like having a skill and not offering it to my patient. Why would I do that? So
I couldn't agree more. That's beautifully said. I love that. We do have a question coming in from Tiffany. So Tiffany and Jane. So Jane owns Phoenix PT, and Jane and Tiffany offer courses there together from the company Biofeedback Solution. Biofeedback. I always forget the name. Incontinence Solutions and Biofeedback. Tiffany, type it in and include the URL so you can right? Because your course is phenomenal. So, the OT-PT collaboration is not new. And in fact, when I first took Jane and Tiffany's course 10 years ago, I was in Phoenix PT. And that was the first time where I was like, the beautiful demonstration of how OTs and PTs can work together, because the two instructors were OTs and PTs. So I love this is coming full circle, that I'm talking to two of you in Phoenix with that awesome OT PT collaboration. So Tiffany has a question, and she's saying, how much are you sharing patients? Do you use different diagnoses if you do share? You can both bill and have different plan of cares. I think this is underutilized in pelvic health.
Yes. And we've talked about that, especially with more complex patients who need additional care, but who run out of
like Medicare,
like limits, right, on the number of visits they can have. And because PT and OT is billed separately, it's a different bank. OT, we can transition a patient, and again, we explain this to them with their consent. We transition them once they've utilized their bank for PT, then we can transition them to OT. I think we've maybe only had one patient where that's been the case so far, but we want to utilize that more so that patients get the amount of care they need.
But I think what Tiffany's asking, and I could be wrong, is like the patient that Jane and I are sharing, like, because we do each have our own current plan of care. We're both billing Medicare, right? So but we don't have too many of those. We could, like, if it was a complex patient, maybe went to see you for something and then came to see me for sensory, we absolutely could do that if the patient wanted to, or if they wanted to come for that many visits, or
that's the thing. Sometimes we run up against us being more eager to fix the patient than they are. But it just speaks to how passionate we are about it, I suppose. But we do bill differently, right? Like you do self-care, you can bill self-care.
But diagnosis codes, we use the same. I use pretty much,
it's a whole grab bag of codes.
I kind of work off of those codes, and then I have a few that I use. But then again, insurance sometimes can play a role in that too.
That's another podcast.
Yeah, because I guess our specific question was, do you use different diagnoses if you do share? And it sounds like sometimes you do, sometimes you don't.
I guess I am using I currently am using a different diagnosis code than Jane is on that one patient that we're sharing.
Right, because you're treating something different
parts.
things. But if we were co-treating for the same thing, we'd probably use the same diagnosis code, but we were just using two different techniques. Like if you were doing energy work for someone with endometriosis, we could potentially still be using the same code, right?
I just wonder, and I don't know enough about this. I've had a private pay practice all of my career, but I wonder if the different diagnoses helps with it not getting kicked out for redundancy of services.
Right. But would it, since it's billed separately, OT and PT, like if it was SLP and PT, that might be more of a problem.
Right. Right.
Yeah.
And
I don't
Tiffany
know.
says it's like stroke rehab, right? When someone comes in with, OT and PT is seeing it, it's the same diagnoses, right?
Right.
And we're both
Yeah.
charging neuromuscular education for a
Yeah.
stroke.
Yeah.
Right. And we're both, the diagnosis is the same.
Yeah.
So
I'm
Yeah. If anyone listening, whether it's replay or live,
yeah.
has experience with this, like share it in, because here's the thing, there's so much in this, we have 4,000 people, over 4,000 people in this community. And I feel like the whole purpose of OT and Power Hours and for us to get together like this is to stop reinventing the wheel, right? Let's just get the information out there. Let's not make it mysterious, because I think the clearer and cleaner, first of all, kindness is clarity. And when we get this information out there, we stop hesitating and we're just able to show up and serve our clients, which is what we all want to do. That's why we're doing what we do. So if anyone has any information on this topic that we're all sort of, figuring out, share it with us so we can kind of learn from that. That's awesome.
Yeah.
Oh my goodness, this has been incredible. I love you two. I love spending time with you. I just love the energy that you bring to the office and for your clients. And I have to say, like, I don't think discipline. I don't think OT or PT when I talk to the two of you. And I feel like the more we can do this, the better we all are, because we can get out of any sort of turf wars, or I just see respect between the two of you. I see this ability to just want to keep learning and showing up and being the best practitioner that we can. So thank you for your time. There's one more question that has come in. Do you have a second for me to ask it?
Yeah.
Awesome. So this is from Carolyn. She says, you may have answered this, but when you shift patients over from PT or OT or vice versa, are you then reevaluating and resending a plan of care to the referring provider? In my clinic under PTs, I strictly see patients and work with an athletic trainer for additional treatment and might consult with a PT or a complex patient. When you co-treat, how do you document it?
Good question. We do a new eval.
So like if I had a patient, then I would do a discharge and then you would do an eval.
Yep. And is it a new plan of care?
Yeah.
Okay.
It's a PT
yeah,
plan of
yeah.
care.
So it's a PT plan of care, and yeah. Yes. Some of these things we do automatically, and we just like, yeah.
She just thinks I'm PT.
Yeah, it's just a PT too. So and we ask for signatures from the physician also. But then we consult with each other, right? Like, I want to know what she did, where she left off, what the patient thinks or doesn't think. And
like why we're switching, what
right.
was it, just a schedule thing, or was it like personality thing, or was it like yeah.
And then try to be
with the peds patients.
That
Peds is
big
often,
exhale.
Peds can be scheduling mostly like with back to school or vacation shifts. Parents want to change schedules, but there's one that's going to be coming maybe to me from PT, and it's just because the mom of the child is an OT and it's her preference.
Yeah.
So,
but there was a situation, right? And I don't know if this is specifically a web PT thing. So I don't know if this person uses web PT. But there was some box we had to unclick between you and Michelle. Michelle's another coworker of ours who's a PT. And in order for her to be able to choose pelvic as her template, or PT as her, I forget exactly, it had to be unclicked. And it was something like, this is not a pediatric plan of care or something like that, even though it was a peds, but we had to unclick that. Otherwise, the only template she was able to use was SLP. So that was a kind of a funny glitch workaround, but it didn't affect anything we were doing. It just affected whether or not the actual chart would pop up for her to be able to chart. So that was a weird one.
PT thing.
It might just be a web PT thing. Yeah. But yes, new eval. Yes, new plan of care.
And then how do you document co-treating?
Well,
How do you
document?
We haven't co-treated together.
If I've had you in the room to do something, I might put something in my note that I consulted with a colleague type thing. And like the patient that Jane and I are currently sharing, she put something like that in her note, and it was like consulted with OT for lymphedema management, consulted another PT for wound care. So we have Michelle does wound care as well. So we all went in and saw this patient.
Yeah,
all
this
the
poor
services.
patient had like the whole circus show up. But I think it's like anything else, you know, if anyone else is in the room, you want to document that, right? So you can't forget that. But I think if it were me, I guess I would say something like, you know, patient reports that she, you know, at previous visit with OT for whom she's seeing, blah, 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 you know, is doing well with blah, 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 if it relates to what I'm doing. If not, I might only do it in that first note where we started co-treating, and then just pay attention to what I'm doing and Susan's doing her thing.
And I think in terms of like true co-treatment, where I've done like co-treatment like in acute care, right, where you go in with the PT and you do like your evals together, or I've done co-treats with speech therapy where we're on the swing and we're doing speech stuff like that. We haven't really done here. Like we don't do that. We haven't done, not that we can't, but we haven't done that where we are both going in to work with one patient for like the whole session. So that we haven't really gotten to.
Which is interesting though, because now that I'm thinking about it, you could be doing Reiki if they have pain with penetration, as I'm doing an internal exam or working with the dilator, for example. Thanks.
Cool.
New idea. Okay, cool. So we're gonna have to figure out how to sign those notes.
Exactly.
But that's doable, right? Like this is something we can do now, rather than me having to talk, you know, calming talk while I'm also trying to pay attention to what muscle I'm on internally. You know, this is all important stuff, and these, you know, it's invasive work. It's scary. So these patients deserve us to be that way with them.
Yeah. And I think you both are just a beautiful model of really putting aside any ego, putting aside any funkiness, and just showing up and serving. And I think that whether you guys were both OTs, whether you guys were both PTs, I don't know that can always happen, because there is a certain amount of, I'm supposed to know this. And that's something that I talk about a lot with not only my OT Pioneer students, but here on this Facebook page, which is something you've touched on beautifully, Catherine. Like, having a robust referral system, both outside of the place that you work as well as within. I mean, you guys are using each other and leaning on each other to really, really focus on that client needs in front of you. And I think the more that we do that, both within our own clinics and in the community at large, we all learn. So everyone listening, like, we're not supposed to know all the answers. We're not supposed to have all the skill sets. And when we realize that, I think it feels really good for the sake of the community, the sake of the client, and us as professionals, because it takes that pressure off, right? We're not supposed to know it all. So lean on the partner to your left and to your right. And if that's not the exactly, if that's not the culture you have, start to develop that culture in your own place. Because I think once everyone experiences it, there's nothing like it.
Right.
It feels really good.
Especially as new practitioners. You know, it's so much pressure going in anywhere and expecting to know the answer. And patients so appreciate when you tell them, I don't know, but I'll find out.
I love that. Yes. And when you do find out and you follow up, because you will, it builds that trust that anything you do share, they know you're saying that with confidence, right? It really lets them know that you're an authentic, truthful person. And it's a beautiful thing.
Yeah.
I am so honored.
Just got a note under the door.
Susan's patients here. It's too much fun. We could do this all day.
Oh, thank you so much, both of you, for taking this time and joining me. A special thank you to Jane for kind of organizing this and having this brilliant idea. I'm so grateful for both of you.
Thank you.
Have a beautiful day.
Thank you.